All right. Well, good morning, everyone. How's everyone doing today? Good?
Good.
And hopefully all the people on Zoom are doing well too. Well, welcome today. My name is Mike Mackert. I'm the director of the UT Austin Center for Health Communication. On behalf of our center and the Moody College of Communication, Bell Medical School, I really want to welcome you to what I'm sure is going to be a great McGovern Lecture in Health Communication today. This lecture was established in 1983 by a gift from the John P. McGovern Foundation. And historically, it's been a way to bring in one speaker a year to talk about kind of their career and the fields of health and medicine and health communication. This year, we had the chance to convert it into a series because we really thought it was important to bring in more different perspectives, more kinds of health communication. So about a month ago, Heather Voorhees was here from the University of Montana, talking about interpersonal health misinformation, which is very timely and was a really great event. And past winners have included, Dr. Scott Gottlieb, the former FDA commissioner, Siddhartha Mukherjee, who won the Pulitzer for his book, The Emperor of All Maladies, and Dr. Julie Gerberding, who is the former CDC director. And so every year it's been a really great event for us. And so we're really excited for today's program. A little background on John McGovern too, and why we're so honored to hold this event in his memory each year. He was a noted allergist, scholar, and philanthropist, and he's considered one of the state's and country's most important figures in the history of health and medicine. He was the son of a surgeon and graduated from Duke University of Medicine in 1945. He served in the Army Medical Corps and in 1951 began teaching, first at George Washington University, then at Tulane. In 1956, he moved to Houston and joined the Baylor faculty. He opened an allergy clinic in Houston, and this part really hit me. His work was defined by combining hands-on medical practice with research and teaching. And everything from the Center for Health Come With Our Mission focuses on bringing together research, education, and practice. So kind of seeing that as a defining part of what was made his healthcare special really hit me today as I was kind of rereading the bio and thinking about what this event means for us. And he was also really known for his humanistic approach and caring for the whole person, not just their illness. And again, it's a huge part of us to think about kind of health comm isn't just part of healthcare delivery. It's public health, it's preventing illness, and a big part of that. So it's just a particularly special event for us, and we really are excited to do this today. I really quickly want to say thank you to the entire CHC team. It takes a lot of people to make this event happen. And so it's all the preparation and design work and people working to kind of get things done on social media. So thanks to Brianna, Jessica, Patricia, Alyssa, Dasha, Natalie. There's just a whole list. I love these kinds of days because there's lots of people who generally don't work together in their day-to-day work who get to come together when we do this big center-wide event. So thanks to the entire CHC team. We really appreciate it a lot. So today's lecture is given by Dr. Jay Bernhardt. He's the founding director of the Center for Health Communication and now is the Moody Dean. And I was thinking back on Jay's time here. A few of us were on the search committee that brought Jay here as our founding director. And I remember thinking personally, I know what a good faculty job talk looks like. You talk about your research, your teaching. I know what a good one looks like. You also know what a not great one looks like. And I remember thinking, what does a center director job talk look like? And we were about 5 minutes into Jay's center director talk. I was like, oh, that is what a center director job talk looks like. It was really clear thinking about the vision of what a Center for Health Communication could be, not just in general, but the thought of what could make it doing it special here in Austin and in Texas and at UT. And it was really inspiring. And I think we were about a year into Jay being here, and something Brad Love said to me, you don't have to say, oh, just always stuck with me. I think it might have been by the time Jay was interim dean. And, faculty life is our research and our teaching and working with students. And that's what we do. And getting the center off the ground was a lot of extra time and energy from the faculty who were here at the time. And I remember Brad saying that he'd never worked with anyone who encouraged him to do things that were so much against his short-term interest, but in service of something bigger, longer term that would pay off with what the center could turn into. And I think that really speaks to the vision Jay started laying out in his job talk and the foundation he laid as center director that we've all kind of had the chance to build on in the ensuing years. So Jay, we're so we're sad that you are leaving Moody. We're excited for you personally, I suppose, that you get to go be the president of Emerson College. But in the spirit of the CHC and what we do here, really wanted to take kind of a chance to kind of celebrate you and thank you. Hear your thoughts on HealthComm. And the program today is going to be Jay's going to offer some opening remarks, and then we're going to shift to more of a town hall format after that. So Jay, thanks again for being here today.
Sure. Thank you.
Thank you. Is there a slide advancer? Perfect.
Yep.
Hello, everybody. Good morning. Happy to be here and share some thoughts with you. And thank you, Mike, of course, for that really kind introduction, and Brad for your quote, and everyone else. It's nice to sort of bookend what will be about 9 years here at UT around health communication issues, which is really why I'm here. Why I came here from most recently the University of Florida. And it's been amazing. I mean, it's been an amazing 9 years. I can't even begin to sort of reflect on all of it yet. It'll sink in at some point, I'm sure. But I thought I was honored when Mike asked if I would be one of the McGovern lecturers this year. You know, many years in the McGovern. I think every year we've tried to do one of these. I guess sort of helped plan the first couple and then have advocated for and tried to help the one since then. I think the one who got away was Rich Besser. I think we asked him 5 times over the course, and I think he went so far to break a hip in order to not come one year. And we've had others we've tried to get over the years, but it's an honor to put my name on the list, I guess. I have about 15 minutes of slides or so prepared. I'm happy we could break during them if anybody has comments or questions, or we could just wait till we get through them and then we'll do some Q&A. I asked Mike for this format so that my prep would be less for what I want to share, but I'm happy to go deeper into any of these topics. But the beginning is really just about reflections a bit. I was reflecting on that talk I gave I think it was March. It was either February or March of 2014. Anita chaired the search committee, and Mike was on it. A few of others in the room were probably on it. And again, I was at the University of Florida. I was a professor there. I was a center director there. I had started a center there called, what did I call it? Center for Digital Health Promotion, maybe, or something along those lines. And sort of, it was around health communication, but it was trying to seize on this concept that was growing at the time of mobile health and digital health. And but it was time to leave Florida. I'd been there 4 years or so, maybe 5, and was on my 3rd dean, and wasn't all it was cracked up to be. And so it was time to make a move. And I was talking to Hopkins and University of Maryland and a few other places, and Texas reached out about an opportunity here, which Texas, I'd been here a few times, come in for South by a few times, and spoke there a few times. The person I knew best at UT was Nell Gottlieb. Anybody remember Nell? So Nell was a friend, longtime friend and colleague of mine through health promotion work, health behavior work. And anyway, but I came in and interviewed and came away really, really impressed. And Texas ultimately made an incredible offer to come in and build something great, and sort of the rest is history, as they say. But I pulled my slide deck from that talk that Mike was talking about, and so I can't see it up there, so I'm gonna have to turn around. But the concept of the talk I gave was a vision for the Center for Health Communication, and the first few slides in this deck I'm not sharing, which was sort of about myself and my path, and I kind of broke it into chapters, like being in New Jersey and growing up and the work I did there and how I fell into health comm. Health comm's kind of a field you fall into, kind of go through high school and say, I really want to go into health communication. So I sort of talked about how I fell into it. And then I talked more about the vision for what the center could be. And I shared a bit on my own research as well, which I didn't put in here, but I grabbed a few other slides from here. And what I talked about was that what a center could be in principle. At the time, Moody only had 2 or 3 centers, had the Strauss Institute for Civic Life and the Knight Center for Journal in the Americas and TIPI. And so I thought, here's in theory what a Center for Health Comm can be, which would be, provide resources, be a place where other faculty and students can come to get support for their work, and a convener to bring experts together from within UT and from within Moody, but even beyond, and a leader in advancing the field, provide health promotion for people in Texas and globally and throughout the country. And also really one of the gems in the crown of Moody College. And And the idea was we do so through research, through instruction, and through service. And at the time it was just words on a slide. It wasn't in reality, but if you sort of reflect on these 9 years, this is a lot of where it's gone. And then I went a little deeper about from a research point of view, how a health comm center can build on people's strength and develop infrastructure and cultivate support from a lot of different agencies. And I talked about an instruction. You can't see this slide, but really goes into courses that were already being offered and new courses that could be developed, graduate certificates and programs and other instructional offerings. And then about kind of what it would take. And so what it would take would be bringing everybody together, developing the shared vision, creating that shared infrastructure, setting some shared priorities, and then implementing. And it's kind of what happened. So I was in that role for a few months as the professor and founding center director. I like to keep I like the title, but I got to do it for a hot minute. What happened then was well, this is actually a great photo of our very first meeting of this group. Oops, let me go back. About I don't know, 30 pounds ago, but you could see a group of a lot of the same folks in the room here who were there then in the LBJ conference room across the street that we've since remodeled. But it was a great meeting and a great discussion, and we kind of had big ideas and plans, and again, a lot of them have come true and come to fruition. And so that's September 14, a few months after I arrived, and then was working. And Mike and I just earlier today reflected on the first people I hired were actually 4 or 5 doctoral student assistants who worked in the center. If we have time later, we could see if anyone remembers them. And then we hired 2 staff, Wendy Stussy, who's still around here at the college, and Emily McKee, who still connected to some of us. But what happened then was I got a call from, I remember very clearly, it was me and Elizabeth Glowacki were coming to meet with Jessica and maybe and Susan over to talk about partnering on health comm texting maybe. And literally that on the way to that meeting, my phone rang, and that was Greg Fenves, who had just become president, asking if I would become the interim dean of Moody. So I don't remember what we talked about at that meeting because my head was spinning from that discussion, but that happened ultimately. And so in August of that year, 2015, I became interim dean. I tried to do both for a year of the health comm work and the interim deaning work, and that's when Brad and others went against their own short-term interests to help build something, because I kind of tapped all these other great faculty to be associate directors and keep the trains running. And then I became permanent dean March of 16. And then said, well, we really need someone to take over for the center. And we were very lucky to, within our own people, to have Mike here, who took over March of 2017 as the director of the center. And if you sort of look at center milestones, which is, I think, the next slide, this was a big milestone for lots of reasons you all know. By the way, Rick, remember this bad logo I made? Back a long time. I think I did it in PowerPoint or so I don't know what it was, like these concentric circles or waves or something. And then I sort of reflected a bit on some of the bigger milestones in the center in its first 8-9 years or so. And we founded it in 2015 with a lot of involvement from many places. We were very fortunate, even in that first year, we had a lot of good luck with some funding from the state in particular, which is sort of a nice sort of foreshadow for where a lot of the subsequent funding came from. But those early like WIC meetings we did and some of the other state-related funding projects. We launched the Health Comm Leadership Institute. We held it in this room, I remember, those first couple of years. And was a lot of work, that first HCLI. I'm sure they've all been a lot of work since then, but the first one I recall was really challenging. We created a strategic partnership with the new Dell Medical School, which was just opening at the time. And this idea of the partnering with the medical school was a really unique concept in health comm, academic health comm. And there really, I think even to this day, there's very few examples where academic health comm brings a partnership between a comm school and a med school. And then hiring Mackert as the director was really the big milestones in my brief tenure as leader. But then, since then, it's been really all, bread and roses or whatever they, I don't know the expression, but mixing metaphors. But, CHC and Mike and many others proceeded to hire amazing professional staff. And I think that was really fundamental to the continued success and growth. And a lot of you in the room on the Zoom among them. Every area of work has had steady growth and progress on projects and funding, affiliated faculty, staff, students, partners, space, reach, and impact. It's been really trend lines have all been, even through COVID and through challenges, have all been going in the right directions. And I think a big part of it is this concept of staying true to the vision of improving health through evidence-based communication. And evidence-based, data-driven, literature-grounded health communication is the fundamental central tenet of the Center for Health Comm and for health comm in general. It's not a service. It's not although there are service activities that can be evidence-based, and it's not a design shop, although design can and should be evidence-based within what we do. And we don't only print trifold brochures or whatever some people's vision or version of health comm or health ed might be, but this concept of a science or science-informed work, I think, is what sets the work apart and why it's been as successful as it has been. But there is an overarching challenge in the field of health comm, and it's before I got on the field, however many years ago, 25 years ago, and for all of you in the field or people watching in the field. And the underlying health communication conundrum is the concept that to improve health and well-being in patients, in communities, and society, health communication needs more support from leaders, meaning support by investment, support by hiring, support by emphasizing and prioritizing evidence-based health communication. It's not very supported. It's a field where we have to always sort of fight and scrap and make the case for why health communication is so important. It's not just known, even after COVID, it's just not known that investments in health communication make greater effective programs, greater health outcomes. So without more support, we need that support in order to design more effective interventions at scale. We can't do the work we're capable of doing without the resources and support from the leaders. But the conundrum is this, that in order to get more support, we need our interventions to be more effective. To make the case to those leaders that money invested in health communication, staffing invested in health communication has return on investment. So it's a conundrum because you can't have better interventions without more support, but you can't prove the case for more support without better interventions. And so I gave a talk on this, if anyone's interested, going into much more depth on this. And then I kind of lay out 6 or 7 or so strategies for ways we might both get more support from leaders and make our interventions more evidence-based, more effective, more data-driven. If you're interested, I gave the talk at the CDC National Conference on Health Communication, Marketing, and Media last summer, and it's online somewhere either through NIFIC or through the conference, if anyone's interested. I'm not going to go into it in depth here, but this continues to be the underlying challenge, I think, for health communication students and professionals and scholars and practitioners is how do we make the case for why people should invest in our work, and then how do we take those investments and make sure we really have maximum impact to not unintentionally undermine the field through ineffective interventions. But when you think about health comm today, you can't think about health comm today without thinking it through the lens of the last 3 years of the COVID-19 pandemic, because this was what could have been our finest hour. It could have been a moment where the whole world sat back and realized that health communication is central and critical and important and life-saving and world-changing, but unfortunately we didn't. And there were health communication problems from day one, or maybe day 5 or something like that of the COVID-19 pandemic. And you all remember these very early days of in March of 2020 and the first few weeks and months since then. You know, one of the big first things that happened, of course, was the Surgeon General telling the country that we should not wear masks, that masks are not necessary or effective for COVID-19, and don't you dare go buy particularly N95s or others, because we need to save them for healthcare workers. And only to then, you know, weeks, months later, completely flip that message. But already sort of the root of conspiracy theories in COVID-19 come from government action taken in the first few days of the pandemic, one might argue. But once you miss the message on that, why would we believe you for vaccines? Why would we believe you for shutting down, you know, and everything else? And so, oops. The same thing on cloth masks. And then, of course, this was the first real global health emergency at scale where mis and disinformation were also at scale. You know, there's always been snake oil salespeople. There's always been people who take crises or health or other things to further their own interests, even at the health or expense of others. But this is the first time that technology allowed it to really be done at scale. And so these are big, hard problems, not to mention all the politics, being in a presidential election year with, you know, at a time of very, you know, disconnected political systems, and creates problems. But nonetheless, I think we could have done better. I think HealthComm could have and should have done better. But the real lessons were that our efforts, our collective efforts in HealthComm fell very short. And some of the ways were that I think these are my personal beliefs, that HealthComm messaging and strategy became too focused on policies and mandates, not enough on educating and informing the public on why they need to do certain things, and more on just thou shalt do this or thou shalt not do that. And guess what? Those messages don't really work. We know that from everything else that we've ever done. So if you thought about the evidence base, you might have said, let's not only go out with mandates and policies. They also require trust to get compliance. And if you, in the absence of trust, we're in a time of record low levels of trust of institutions, including government and including healthcare. And so mandate and policy driven interventions do not work in general, let alone trying to do it at a time of, you know, record low levels of trust. The interventions, the government interventions for the first year or more really ignored, in fact, even in some cases fed into the mis and disinformation campaigns that were actively ramped up. And a lot of it tapped into issues around vaccine safety, which had been, you know, for the last 20 years had been an issue around childhood vaccine. And the same actors who kind of acted on against, you know, incorrectly, I might point out, acted against the safety of childhood vaccine immediately seized on this concept of COVID vaccines not being safe. And many, all best practices were really not used. The most obvious of them being the very simple communication and marketing concept of audience segmentation, meaning you understand how and why people think or feel the way they do and create targeted messages at different audience segments based on what we know about them in advance. The government and others could have so easily created, you know, meaningful audience segments around COVID messaging and created different messages from different sources with higher credibility for those various audiences, but this was not part of the strategy at all. So some big mistakes made. And then effective scientific communication expertise and messages were still needed at all these different levels, but they just weren't there. The other thing that the government failed to do is use their own plan. There actually is an incredible plan called the CIRC Guide, Crisis and Emergency Risk Communication, that CDC's produced for decades. Pretty much every other country on the planet uses this for how they do emergency and risk communication. But for whatever reason, the CDC, well, we could get some of the reasons, but the CDC did not use this as like the handbook for how to respond to the emergency. So some mistakes were made with pretty significant consequences for health and welfare and communities, but also for the field itself. So the state of communication, of health communication now coming out of the great pandemic, or whatever we'll someday call it, is I sort of say glass is, depending on how you look at it, half full or half empty, right? It's not, there's challenges and there's problems, but there also are some opportunities. And the opportunity is that there's more awareness now among policymakers, stakeholders, leaders, that health communication is important. It's necessary. Even CDC, which is going through reorg, is going to, I heard yesterday a little bit about the structure of bringing together some communication units under a new name. That's something. It's probably not sufficient, but maybe a small positive step. But it's not all been announced yet. But the expectations are lower. So now the people say health comm is important. Clearly, how you communicate matters, both in emergencies and for health issues in general. But we also, many people think of the conundrum again, but it didn't work so well. So maybe we can't expect great impact, great effects. Small r squareds for the meta-analysis people in the room. There's increased commitment. People know it's important, but there's no standards. There's no process by saying, here's the best practices for doing health communication for this issue or for this audience or for this organization. So without having standards on which to base all this on, people just make it up. People, many health communication practitioners just kind of make up what they're doing. We'll throw this theory in there. We'll throw this model in there. We'll use these 3 steps from Prochaska, and we'll call this a health comm intervention. But that's not, would you do that in medicine? Would you ever kind of treat a condition just making it up as you go along without at least thinking about what? Now, there's always variation. There's always customization, but you would never just make it up. You would grow on the evidence base of what the evidence suggests is the most effective way to do something. But in health comm, in too many places, it's still, people just make it up. There is the potential for some more research funding. But right now, there's really no significant infrastructure investments or government champions. And this, I had like 3 slides on this concept in that CDC talk, because for decades, the reason we got to where we are in health comm today was because of huge investments primarily from National Cancer Institute in the 1990s, when Barbara Reimer was leading a division there. And they invested in funded centers of excellence. They invested in research that led to the whole concept of tailoring. And they did a lot of they did research a lot around how to improve cancer screenings using different communication strategies. So those investments in the late 80s and early 90s out of NCI led to great programs out of CDC and elsewhere in the early 2000s. And then, they've kind of fallen off since probably late 2000s. And the other thing I talk about in my other deck was I sort of blame Tom Frieden, indirectly a former CDC director, for a lot of these problems. Because when he took over CDC in 2009, he had still has a different philosophy of effective public health, which is using this thing he calls the public health pyramid, which is this idea that we shouldn't invest in communication, education, social science, and behavior change. We should just change systems and policies and engineer. It's sort of like the lower level of the Haddon matrix, for those who might know that. And he's wrong. Just point blank, he's wrong. It didn't work it fell on its face in COVID and caused a lot of problems and bad outcomes. And so, but we don't have a champion. There's no federal agencies that have since stepped in to champion HealthCom. Some of them keep suggesting they might. NIH has started to create some new discussion groups around what they can and should do to fund better HealthCom research. I mean, the communication technologies have changed so much that what the work out of NCI back in that day is not quite as relevant. And so there needs to be a resurgence of this work. Remains to be seen if it'll happen. There's just very little power or influence in healthcare and public health that focuses on HealthCom. There aren't HealthCom leaders above, many organizations in healthcare and public health. There aren't people writing op-eds saying we need to focus on this. There's not the kind of overarching leadership. I'm going too long, I know. I think I have one more slide. So is it glass half full or the glass isn't empty? Like at least the glass isn't empty, right? It's not empty. It's maybe not filling up as fast as we would like, and maybe that's water from Flint. But it's at least half full. So what does that mean for HealthCom at UT? I mean, mostly it means you got to keep doing what you're doing and maybe think bigger. Probably that's the way I would describe it, is keep doing what you're doing, but think bigger, because it's needed. And so I think things continue to, I mean, DelMed, we're on kind of DelMed version 2.0 now, 2.0, new dean, new perspective, new opportunities, new investments probably coming, on the clinical care side. Certainly there are going to be a big emphasis on how to scale more of that. On the research side, I suspect under the new dean, there'll be greater emphasis on federal funding and research funding, and whether that's CTSI or that's other types of big research funded opportunities. I think there'll be great chances there. So it's really a reboot with DelMed and a good chance for the center to play a big role in that. I think seeking fewer but larger grants or its government contracts. I put in here the notion of earmarks. I think the kind of work the CHC does lends itself to the concept of like direct state appropriation type work. There are others in the state who've been very successful in getting some of those kinds of funds. And so I think something that CHC should continue to explore, but having a few large grants that are longer is a lot easier to manage and creates much more staff stability and those kinds of things. So something to keep working on. I do believe that instructional programs are important to develop and scale, particularly because more people need to learn how to do evidence-based HealthCom, but also it can and would create some revenue streams, particularly if you look in the area of option 3 programs and executive ed programs. I think HealthCom is very well positioned for those. And I encourage you to nudge the next dean to support it. And then the notion of continuing involvement of more and more faculty and staff and students and partners. I know that's already a priority, but you can't ever stop doing that. You want your tent to keep growing. It's never really big enough. And in part because of departures, and in part because of students are here only for a period of time. And, thinking about how do you raise your profile? How does the center and HealthCom at UT raise its profile? You have a great reputation already, but I think that you might want to think about other signature programs or other journals or other, leadership of organizations or other ways to make it even bigger and more well-known. Because there is no other institution like this one in the US. But not many people outside of Austin don't know about it. And then I think it's just really keeping up what you've been doing, but trying to scale where you can. I think that's my last slide. So I went more than 10 minutes or 15 minutes, but that's what I wanted to say. So thank you.